Good afternoon, everyone. My name's Chris Wood. I'm a pharmacist by background, so I work 2 days a week at the Bennett Institute as a clinical informatician, so looking at prescribing data and working on open prescribing amongst other projects. And then the other 3 days a week, I work as a prescribing pharmacist in general practice. So today I'm going to be talking about open prescribing, particularly aimed at primary care teams. So we need to have a bit of a think about where primary care prescribing data comes from and what it is. So obviously, I'm sure you're all familiar with FP10s. So we need to think about kind of the journey that these take. So in primary care, these are written mostly from GP practices, obviously written by a variety of people. So from, say, GPs, from prescribing pharmacists, prescribing nurses. So it's not just GPs anymore. This prescription's then sent to a community pharmacy who basically process the prescription, supply the medications to the patient. Pretty much all of these prescriptions nowadays are sent electronically. There's probably a few that are sent by paper, but they all kind of then follow the same process when they get to the pharmacy. So pharmacy supplies the medications to the patient, and then at the end of the month, they need to basically make sure they get paid back for whatever they've supplied and what services they've done. So they send off all these prescriptions to a body called the NHS Business Services Authority, the NHS BSA. They then collate all this data together, work out what prescriptions have been supplied, what services have happened in community pharmacies, and then their responsibility is to make sure that pharmacies get paid accordingly. So they get reimbursed for, say, the medicines that they've supplied, the services that they've done, the dispensing fees, all those sorts of things. As a kind of a consequence of this, the BSA ends up with huge data sets. Every single month they get lots and lots of prescriptions, lots of information back. So it covers things like, which patient received a prescription, what medication was that prescription for, who prescribed that medication, which pharmacy dispensed it, how much did they get, how much did it cost. So lots and lots of detailed information is then kind of generated on prescribing and what happens. Then from this, the BSA make a subset available openly online. So there's obviously the different kind of extracts that exist, but the one we focus on today is the NHS Business Services Authority English prescribing data. Slightly confusingly named because this is what they call a dispensing view of prescribing data. So although it is all prescribing data, it is only things that have been dispensed as well. So it doesn't include prescriptions that have been written for something that has not been supplied to a patient. So this is, I say it's a subset, so this is certainly not the full thing. So obviously one of the big things is that they take out all patient level data. So for obvious privacy reasons, so they can't make it openly available what individual patients' medications are on. So they strip that out, but there's still lots and lots of detail in there. So particularly what we're interested in is it tells us what individual, say, GP practices or collections higher up than that, so PCNs, ICBs, have been doing. So what they've been prescribing, what's been happening there, and help us look for any trends or any changes. The data comes out every month, so there's a new release of data every single month saying what happened. There is a little bit of a lag, so obviously the BSA gets so much data that it does take some time for them to kind of consume and process. So we think there's roughly about a 2-month lag. So for example, we're around the middle of September now, so probably in the next week we'd be expecting to get July's prescribing data come through, and then we'd then work to make that available through open prescribing. Open prescribing, we try not to have too many complex terminologies and definitions. There's probably these two are probably the most important ones for today and just in general in terms of looking at open prescribing. So we talk about two different kind of units of measure. So one is items that we might talk about. So this is the number of times, say, that an item has been prescribed. So if we think about, say, amlodipine, 5 milligrams for an example, prescription for 28 tablets of amlodipine 5 milligrams would be one prescription, so it would be one item. Then the other unit is quantity. So we talk about the total amount of medication that has been prescribed. So for solid dose forms, it's pretty straightforward. It's generally things like the number of tablets or capsules. So for the amlodipine example, it would be 28 tablets. It does get a little bit more kind of messy when we start thinking about different formulations, and it's definitely not possible to combine all formulations of quantities. So for example, if we think about liquids, they're often come in measured in a quantity of mils. So you can't add together the number of mils of amlodipine and the number of tablets of amlodipine to get you a sensible quantity. So just to be aware on that. So this is a very small amount of the kind of the monthly data that gets published. So you can see there's lots and lots and lots of columns. I'm not even sure that's all the columns there that exist. And this is 33 rows, but there's millions of rows every single month that come out. So these data files are pretty huge. So you could just about download and open one month of these in, say, Excel, in modern versions of Excel at least, but they're about 6 gigabytes each. So if you're interested in, say, what prescribing trends are happening across the country, things like that, you would find it impossible to do in Excel because you would need to open so many 6 gigabyte files. I think your computer would fall over at some point. So this is where OpenPrescribing comes in. So we take these data files and we present them in a way that we can facilitate benchmarking, so benchmarking across different GP practices or different levels, and also make it much easier to do further analysis. And I'll go into in a little bit more detail further in the talk. So OpenPrescribing, if you haven't come across it before, hopefully lots of you have, it's openly and freely available for everyone. So there's no need to log in, there's no need to pay anything. It's just there online. I think Hilary has already shared the link, so openprescribing.net. We're happy for anyone to use it. So, we get emails from patients who've been looking at it, and there's no restrictions on who can use it, who can access it, who can look at what. We have about 20,000 unique users every month. We think the majority of these are from people employed in the NHS, which is, as we'd expect. A lot of them are based in ICBs, so this is things like your ICB team, making sure things are being well managed in primary care, looking out for kind of quality improvement areas or cost improvement areas. But we also know lots and lots of people in kind of individual PCNs or practices are also using this. So I use it day to day, or at least month to month, to kind of keep a track of what we're doing, where we're at. So you can use it to things like benchmark how you're doing against others in the PCN or across the country. Think about how we're doing. Are we delivering the best care? Is there anything we can improve on? It's also quite satisfying to kind of track changes as well. So if you've made some big changes in certain prescribing areas, you can view it in OpenPrescribing. You can kind of see those changes happen over the months as new data comes out. So the idea behind OpenPrescribing is that you can use it to kind of identify things that have potential for, say, improvement or need kind of further discussion or action. There's a few kind of analytical choices that we make in OpenPrescribing, so some things that we include and some things that we don't include. So our focus really is on GP practices and individual GP practices, and from there, so we don't include things like, say, out-of-hours centres or urgent cares, or say, things like specialists, community heart failure teams, things like that. We don't include them in our measures and things like that, just because they're kind of practice is just totally atypical to what a normal GP practice would be doing, and it would skew the data. We also make different choices so you might find things don't look exactly the same as you might see elsewhere. So this example here is kind of an example of one of our measures and how what we present just differs from what others might present. So this is looking at kind of broad spectrum antibiotics as a total of all antibiotics. So you'll often see, I think, in EPACs and possibly in Prescript, they have similar measures, but they look at 12-month rolling data. So you can see it's kind of a smoothish line, and it has peaks and troughs and ups and downs, but it's generally not changing too much month to month. And that's because they work on things like 12-month rolling data. OpenPrescribing, we present everything month to month to month. So you will see each individual data point just represents that 1 month of data. So quite interestingly here, if you compare the two, you can see that there's quite a big difference here. So this is December 2022. So we can see there's a really big dip in the percentage of broad spectrum prescriptions happening here, December 22, whereas you can't really see it. You certainly can barely pick it up on this rolling 12-month chart. So this was when there was the big Group A strep outbreak, and there was quite a large increase in prescribing of Group A specific antibiotics. So not these broad spectrum ones, but the other antibiotics, things like penicillin, amoxicillin, clarithromycin. So basically effectively diluted down this percentage and just brought that percentage fairly sharply down, but obviously it went back up the following month. So we kind of like to see these things happen. Also, perhaps, if you put some changes in, sometimes quite frustrating to see that line very, very slowly reduce down, whereas actually if you look at the monthly data, you can see a pretty sharp drop of where you've made that change. We also tend not to do too much adjusting of data. So we know that registered populations can vary quite significantly between, say, regions or even between practices. But we do think sometimes adjusting for these things, using things like star PUs, astro PUs, those sorts of things, can provide some false reassurance. So, if you adjust for one of these and it's not quite accurate, then it might provide some false reassurance. Maybe you think, oh, that's fine because of that's looking low, and actually maybe that's not the right way to look at things. We think you probably know your practice best, and you've probably got a good idea of, say, what happens at the other practices in your PCN. So we present the data generally as it is, and then allow our kind of users just to adjust the data themselves, either in their head or using their own data, say, on hand. Right, okay, so that's kind of the key information, I think, about OpenPrescribing. So we're now going to move over to this practical demonstration today. So I'm going to try and go quite slowly through this, and I'm going to try and point out where we're at. So firstly, we'll go to openprescribing.net. So the idea today is, if you want to, you can try and follow along. So you can follow along for your own PCN or practice. I think we are a little bit limited for time as well. So I might not be able to go as slowly as needed, but if you want to, you can follow along and have a look at what's happening at your practice today as well. Right, okay, so we are interested in, so this brings us to our homepage. So you can see this is quite a new thing that's just popped up. So here's our news. So we write things like blogs about interesting stuff that we've spotted or changes that we've made, so you can keep track of things here. But then we're going to shoot through here to this bit here, which is probably the main link you might go to first. So this allows you to pick an area and practice dashboard. So you can look at prescribing across a whole range of things. So you can look down at, say, individual practice level. You can look at the whole of England, or you might be interested in, say, what's happening regionally or across ICBs. So you can pick what level you want to look at in this section here. Today we're going to start with PCN and then also work down to practices. So we have some in the chat. So we've got coastal PCN in Devon. So let's have a look. U55397. Oh, maybe I need to do coastal PCN. Here we go. Coastal network PCM. So we can load this up and we can have a little bit more information about this PCM. So you can see this is 3 different GP practices, and then this one that's closed. You can have a look at, say, the one that's closed, and you can see closed a good amount of time ago. So June 2020 is the last time, or closed August 2021, but there doesn't look like much data for a long time there. So that's probably not going to pop up too much and worry us too much today. So we can see then that there's 3 different GP practices in this, and we can see roughly where they're based, just north of Torquay, south of Exeter. This is one of Rich, who's one of our other clinical informaticians. It's in Devon, which is one of his areas. So I'm sure we'll see some interesting stuff today. So you'll find all the different kind of all the different areas that we look at. So if you're looking at a practice, a PCN, ICB, even All England, you'll see they all have very similar views. So you can click through to one or the other, but you'll see they're all quite similar views and similar kind of layouts on the page. Some things are available only, say, at practice level. So I'm going to click through and show you different bits today, because it might not be that everything is available to look at on a PCN level. But I think PCN is a good place to start, just to give us an idea of what's happening and where to look at things. So these are probably the biggest things we're going to focus on today. So these are what we call our measures, which are kind of where we put our kind of benchmarking stuff. So it's where we think maybe these are indicators of practice that is either going well, or whether maybe there's areas for improvement or things could get better. We try not to say worse, because it's not always that they're worse. They're different. They're outliers often, but it doesn't necessarily mean something bad is happening. It might just mean that something specific is happening in that area, or there's good reasons why things are high. So these are the charts that we have. These are the standard charts. So the red line is probably the one you're most interested in. So this is the organization you're looking at. So for here, we're looking at the PCN. So this is what the PCN level performance is. If they're all interactive, so if you hover over, you can see different time points and different bits of data at different time points. So we can see June 24 is the latest piece of data here. Tells us what the numerator is, so the top number, prescriptions for Lancet's not in the guidance, and the denominator. And it tells us what percent the measure is at and what percentile they're in. Then we have the blue line. So this big dashed blue line here is what we call the national median. So 50% of practices data for this measure is below this, and 50% of the national practice performance is above this. So this is kind of where 50% are. So if you're above it, you're in the top half. If you're below it, you're in the bottom half of the country. And then each of the dotted lines are what we call deciles. So you can see this is 50%, then each dot is a decile. So that's the top 60%, 70%, 80%, 90%. So anything above this, say this top line here, is in the top 10% of the country, or the highest 10% of the country, or whatever phrase you want to use. We do try and, when we design these measures, we try and work out how to phrase them best, and how to make them be that low is good. So if you are towards the 100% or towards the top end of the chart, or above the dashed blue line, it probably means that you're there's potentially room for improvement, or you're not doing as well as, say, other places are. If you're at the bottom, then that's probably an indicator that you're doing really well, or doing something well compared to others. So we can click through. There's this button here, so it says view all 81 measures, and I would suggest this is where you start when you're looking at your own PCN or your own practice. So you can click through here. So these are the 81 different measures that we have in place at the moment. We're changing them around quite often, so there's new ones being added, and there's some being taken away or updated kind of constantly. So you can always kind of keep an eye, and we try and write in things like our newsletter when we've removed some, or when we've added new ones. So here it should load all 81 measures, and kind of an important one I think a lot of people miss is that there's logic in how we present these. So they go from ones where you're kind of the higher outlier, so where there's potentially room for improvement, or probably where you need to kind of review what's happening, down to where you're really low. So often where it's basically zero, so where there's nothing to do, or where numbers are really low, or where you're way better than what's happening kind of nationally. So I'd say if you're using this, I would say always start at the top and work your way downwards. So we can pick one of these measures today. I'm not going to pick testing Lancets, because I know there's definite good reasons. I'm sure Rich will tell me there's cheaper Lancets than there are in the NHS commissioning recommendations. So there's good reasons why things might differ. So this one here, maybe. So this is quite a good example. So this is anxiolytics and hypnotics, average daily quantity per 1,000 patients. I'm not going to spend too much time going into the very, very kind of specifics of each measure, because different ones are important for different practices. But we have this section here, so why it matters, and we've written this individually for each measure that we put up. So we put quite a lot of time thinking about what we're going to present and kind of defining how the measure is built. So these are not really things that we've just thought up off the top of our head and launched. They're often based on national guidance, international guidance, good practice recommendations. So there's generally pretty good reasons why something makes it into a measure. We'll always try and give links or kind of facts or figures or details. So this one is basically prescribing lots of anxiety, like anxiolytics and hypnotics. Long term is not a great idea. So things like we're talking about benzodiazepine, diazepam, temazepam, zopiclone. So have a read there. I think before you get into any more detail, have a read about what the measure is and why it matters. But then we can drill into a bit more detail and we can get a bit more information out of this. So we can see, if you look at the chart, we can see there are the 97th percentile, so kind of in the top 3% of the country, the highest 3%. And this is the average daily quantity per 1,000 patients. So there's a little bit of kind of normalizing done here, just to account for, say, if your practice is a huge practice, obviously you might do more prescriptions. So we've tried to account for that here. So then we can click through to have a little bit more look at detail. So we can click this one here. So we're in Explore. These are all the other options. So break the overall score down into individual presentations. And that takes me to this page here. So here you can scroll down and you can see what is being prescribed. So it gives you a bit of a better idea about what's going on. I don't think this is a huge surprise. So zopiclone 7.5, zopiclone 3.75, diazepam. So none of them are kind of particularly extravagant, particularly unexpected drugs to be prescribed. Sometimes, you might find something weird, unusual. Often if you scroll down to the bottom and have a look for ones where there's low prescriptions, things like liquid oral solutions, lormetazepam. So there's a little bit more information there that you could have a look at and say, oh, that's unusual, that's unexpected, things like chlordiazepoxide. So you can have a look there and see what drugs are contributing to this being high. Then we might think about, because we're looking at a PCN, we might want to have a think about what's happening at individual practices. So again, in this Explorer, I can go back to the other one. There's an option to split this into individual practices. So let me click it. Yeah, okay. So then here, so I've got a new page with 4 different charts, so one for each practice that's in the PCN. Obviously this is the one that's closed, so there's nothing really relevant there. And again, you'll see these are ordered from best to worst, or however you want to phrase that, highest to lowest. So Barton Surgery seems to prescribe the most of these drugs per 1,000 patients. Channelview, something odd happened there. June 2020, there was a lot. Trying to think, doesn't seem particularly related to the pandemic. There was something odd happened there, I would say, and then it all seemed to settle down. Don't know. We could have that's something you can have a look into more detail, I suppose, and see what happened there. Yes, someone's saying there was a merger. Yes, that's sensible. Yes, so there was a merger from one practice to another. There you go. So you can see something happened and then it settled down again. So that's kind of good news. And then this one's kind of always been performing about 50%, and then it's slowly creeping up. So we can see that sort of going off. So sometimes this is quite useful just to compare practices across your PCN and say, is there something different? Say they've changed something. It's nothing. I suppose they're all kind of ticking along here. So if one of them had suddenly reduced down or done something, it might give you an idea that something big had happened, or maybe they've done a quality improvement project there. It's worth contacting them and finding out a bit more. Can have a look at another one and see if there's anything particular. This one here is often quite an interesting one, so we can compare things like practices. So we can see this one here, Tain Estuary Medical Group, has definitely started to tick down. So it looks like there's some work happening there compared to the others. But you'll see this is probably one that lots of people have made bulk switches and things like that. So this is the national median. So there's been huge changes nationally here, whereas these are a little bit slower on the uptake perhaps. But some of them are definitely doing work, and some of them are slowly ticking along, I think, in the right direction. So that's the kind of the measures, and that's what we think about. Then the other thing that we can do, let me get back to the one I was on. So this is the Analytics. You can see this on the Analyse page. So view this measure on the Analyse page. You can click through onto here. And this tells you, basically it auto-fills our Analyse tool with all the drugs that we're interested in, so all the drugs that we're looking at here, and then presents it on this big chart here. So we are looking at, I have to remind myself, Coastal Network PCN. So we can look at this PCN work, PCN. It's loading quite a lot of data, I think, for this one, so it does take a little bit of time. Okay, so we can see, so this is plotting every single PCN in the country. So we can see, I think roughly as we've seen in the chart, that they're in the, the highest, at least higher than 90%. So we can see they're up there, but then you might want to know if this is, say, a Devon thing. So we can look at NHS Devon, can filter it down a little bit more. Because obviously there's regional differences, there's differences. You can see it's still quite high even amongst the other PCNs in Devon. So just useful information to give you to help you benchmark a bit further and see are things as we expect? Is there a good reason why this is happening? Right, okay, so I'll close those. And then the last thing I suppose to mention on the measures page is we have these download data buttons. So we have them here and here. But basically, you can download the data that's behind this measure. You can open it in Excel and you can manipulate it separately if you like, or if you want to get a bit more information out, there is that option there. Okay, then back to the measures page. So again, I mentioned you can scroll down and see the ones where things are going well. So this one here is a nice example. So we can see courses of amoxicillin for greater than 15 days. So we can see there's been so they were in the 97th percentile, and then there's been a sudden change here, and it's changed, and they are now basically in the bottom 2 percentile. So really big, really sudden change, really good change. You can see something drastic has happened. I think that's happened much earlier. You can start to see other kind of the national median come down. So I think lots of other places are working on that, but much more recently than 2022. So I would say start at the top if you're looking for things to improve on, but also don't forget the bottom things, because it will show you, it will show you're doing things well. It will show the good practice that's going on. So always have a look at both ends and see, or you might have some quick wins here. So things like, I don't know, diltiazem greater than 60 milligrams prescribed generically. So there might be small differences between brands. So ideally you should be prescribing a specific brand of diltiazem modified release. There's one item every couple of months. So that's probably one patient that needs just a quick review and changing to a brand specific prescription. Right, okay, so that's the standard measures. Then there's a couple of options here at the top as well on these pages. So if you say you look after a specific area, you've got a specific interest, you can pick by category. So we try and categorize them. So for example, if you do diabetes, you can select just to see the diabetes measures, and that breaks these down into a bit more detail here. Whatever other measure, antibiotics is what I look at a lot for our practice. So we've got lots of different antibiotic measures, antimicrobial measures. So definitely have a look and have a play around. Have a look, maybe try and have a look through as many as you can to start with, but then also start drilling down into the ones that you're interested in or the areas that you're most involved in. Right, and then if we go back to the PCN page, go back, does it take me back? So this is the starting page that we started on for the PCN. We can see here this other kind of set of measures called the low priority measures. So these are the NHS England items that should not be routinely prescribed in primary care items. So on here, you'll see like a composite measure. So this is a combined cost for all of the different kind of categories in this guidance. But we can also click through here to view the 24 individual measures. I'm not going to go into great detail here because you'll basically find it's similar to what we did before. So amiodarone, so ordered from kind of highest to lowest across 6 months, you'll see amiodarone is top here. So it's quite a lot of amiodarone prescribing going on in this PCN compared to nationally. Again, you can click through, is it, well, it's all going to be, presentation's not going to be exciting because it's all going to be amiodarone. You can have a look for individual practices. So again, they're all quite high. So maybe it's something kind of regional. So you can have a look at that. But yeah, so these are basically a separate set of measures, but very similar in terms of how you interpret them, how you read them. They've all got why it matters and things next to them as well, and they all link into the kind of the standard guidance. Right, okay, so then moving onwards, if we go back to the home page, yep, we're back here. So one thing I would definitely encourage you after today is to think about signing up for our alerts. So every month as we get through the data, we ingest it, we process it, we update our charts, and then we send out an email to everyone that's subscribed, basically telling them what's happened, what's updated, what's changed. So if nothing else, it's kind of a good prompt that the data is updated and you can see new data in OpenPrescribing, but also you get an email that's personalized for wherever you subscribe for. So if you subscribe, say, for this PCN, you will see a little bit more detail about what's happening in your PCN and what's changed. We're working on the wording of all this at the moment. I think I'm always trying to carefully choose my words. But you might see we say worst prescribing measure or measure where there's most room for improvement. So this will tell you what you're kind of higher on. Things that are changing, so where maybe things are going off and where it's time to maybe have a think, and maybe it's good to pick these up and action them early. Possible savings, so where you might make some cost savings. And then also at the bottom, things about what's going well, so where you're doing well, where you're in the best in the country, where things are getting better. So it's quite a helpful email, I think, to get through every month, just to say, this is where you're at, keep track of this. And if you're monitoring things, it's a really helpful prompt. So I think Hilary will share details. There's like a blog on how to subscribe to these, but you can do it at different levels if you want. So here we're on the PCN page, so you can put in your email address here, and you will subscribe to an alert for this PCN. If you wanted to say just have a look at your own individual GP practice, you would just pick the GP practice, Barton Surgery here, for example. And again, it's the same box. If you put your email address in here, then that will sign you up just to get email alerts just for your individual practice. So it might be you want a practice, it might be you want PCN, it might be you want both. You can sign up for as many as you want. Right, okay, then next we will look very briefly at ghost branded generics. So here, actually, this is an example of where you might need to have a look at a practice rather than a PCN. So like I mentioned before, there's different tools that are available only at practice level. So ghost branded generics, one thing that we think about, the amount here is pretty small, £250 a month. So there's probably, I'm not expecting to find a lot in here. But we'll have a very quick look. I think what I would say is have a look for your practice, your PCN, and see, is there much there? Is there not much there? Is there much to save? Is there not much? Often you'll find there's probably not very much there. So ghost branded generics, basically when you prescribe say a generic drug, you might prescribe naratriptan as the example here. So generally you prescribe it naratriptan 2.5 milligram tablets as a generic prescription. But there is always an option in your electronic healthcare records to prescribe it at a kind of a more specific level. So naratriptan 2.5 milligram tablets is a generic prescription, but also specify a particular manufacturer. So Teva UK Limited here is the manufacturer that's been specified. This used to be a lot easier to make this mistake generally. And after some work, OpenPrescribing team did 4 or 5 years ago, I think, there were quite big changes made. So it's much more difficult to pick a branded generic or a specific manufacturer version of a generic prescription now in the electronic healthcare record. So it's probably unlikely it's happening much day to day. It might be that there's some historic ones hanging around. So what we look at basically here is we're saying, so we know that if you prescribe, say, for a specific manufacturer, it will be that there's a slightly different price paid for these drugs. So it might be higher than what you would generally pay for a generic prescription because you've specified a manufacturer. The data that we get doesn't tell us which ones are ghost branded generic prescriptions and which ones aren't, but we use a little bit of kind of logic to work it out. So what we work out is how much you're paying per unit, so say per tablet for that item, and then we compare it against what everyone else in the country is paying. And if you're paying more and you're prescribing the same thing, it's likely it could be a ghost branded generic prescription. So here we can see for ivabradine 2.5 milligram tablets, this practice is paying £1.04 per tablet, but nationally, or the drug tariff price would be 71p per tablet. So there's been a slightly higher amount spent here. So I would say just go back and have a look at your ivabradine prescriptions and see if you can identify one is a ghost branded prescription. It might be that they're not, and there's other complex things going on with prices, but it's worth having a quick look anyway, because it's often a very easy fix. Fine, so that's ghost branded generics. I think Hillary will share a blog. Maybe it's already shared a blog. Yes, it's already there as well. So there's lots and lots of different blogs that we've written about all these different kind of features as we've added them. So they're all appearing in the chat, and you can have a read later if you want more information. So ghost branded generics, I'd say have a quick look, but don't spend too much time on it. Right, and then the next one we will have a look at is the price per unit. So I mentioned briefly under ghost branded generics, we can look at how much you're paying per tablet. But this is another tool that we use. So this gives us an idea of what you're paying per tablet or per unit, depending on what the formulation is. And again, compares it against what's happening nationally and tries to identify if there's some money to be saved. This isn't quite as straightforward as, say, it looks. So there's a lot of complexities in how things are reimbursed. So generally we always say, or the NHS always says, prescribe generically to get the cheapest price. There's certain times though where that's not always the case. So there's certain, say, branded generics that might be slightly cheaper than prescribing generically, or it might be that a slightly different formulation is cheaper. So there might be, I don't know, things like Ramipril as a tablet and a capsule. So it might be if you changed all your Ramipril tablets to capsules, there would be money to be saved there. So we try and work out again what roughly is being paid at your practice and what's being paid across the country to try and identify any differences. So quetiapines, I don't know if that's up here. I'm not going to go into quetiapine. Actually, yeah, we can have a look at quetiapine. I've got a rough idea. It's obviously been in, I think, price concessions recently in SSP, so I don't know if some of it's influenced by that. But we can click through here and we can see the Barton surgery in particular. So you can see 2 big dots here. So we can see that Barton surgery prescribe quite a lot of the brand originator Seroquel. So 535 units of Seroquel, 100 milligram tablets, and that's £2.26 a tablet. And then some generically prescribed quetiapine, so quetiapine 100 milligram tablets, generically prescribed at 27p a tablet. So you can see there's a pretty big difference in price per tablet there. So you'd want to know, is there a reason why those have all been prescribed, why half of the prescribing is for the brand Seroquel? Is there something locally happening that means that's the reason? Has it been a recent price change? There might be some good reasons, so I would say always have a good think about before diving in and changing things quickly. So it might be your ICB team have a plan or are aware, or some of these can be kind of transient things. So it might be that 1 month something's cheaper, but then the next month something else is cheaper. So it's not always worth spending the time going through all of these and changing everything immediately. I think this inhaler is probably another good one, beclomethasone formoterol. So you can see for the Barton surgery, basically all their prescribing is of Foster. I don't think there's any Lufabec there, but you can see nationally that although there's lots of Foster prescribed, this is generic. Lufabec has recently come onto the market and is a lot cheaper per inhaler. So it might be worth thinking about switching those Foster prescriptions to Lufabec, depending on obviously what's happening locally. So again, not always a list that you need to action every single thing here, more of a prompt to say, oh, is there a good reason why we're doing that? Or is there not a good reason? Is there a good reason why we're prescribing Seroquel, say, or not a good reason? And maybe there is. So have a bit of a think and go from there with the price per unit ones. I'm going to touch very briefly on price concessions. I think it's not hugely relevant or hugely important to you in, say, in an individual practice. I think having an idea of price concessions is useful, but I don't think it's generally likely to change practice too much. So very brief description of price concessions. So there's the document, the drug tariff, which sets out the standard price that a pharmacy will get paid, reimbursed for supplying this particular medication. When, say, a particular product isn't available, so say one of the generics goes out of stock and only the brand's available, then obviously that means that the pharmacies just won't be getting paid back for the medication that they're being asked to supply, because the brand costs more than what the drug tariff price says. So we, oh yeah, someone said shortages with the Seroquel. Yeah, that makes sense. So yeah, so the Department of Health agree what we call price concessions, where they agree to pay a slightly higher price for a short period of time, so say a month, for the branded product, say, to cover the cost or part of the cost of that, so that pharmacies aren't making a loss, or hopefully not making a loss on the medications they're supplying. So some of them can be, really small units, small prescribing, low numbers, low cost. Some of them can be quite big jumps. So I think apixaban, yeah, there we go. So we can see apixaban is top here. That's what I would predict. So there's a price concession going around for apixaban at the moment because there's generic apixaban that's available really cheaply, generally, but at the moment only the brand is available, which is many times the cost. I think about £60 a box. So that can cost quite a lot of money when you add that up for every prescription that the price has gone up by. So we try and provide basically an estimate month to month of what's likely to happen with price concessions and how much it's likely to cost. So you can see at this practice, we think it's going to be about £23,000 in this month, and you can see it's somewhere around £15,000 generally. A lot of the time, there's not tons you can do about these things from a local level. So apixaban generics are not available, so the pharmacies are getting roughly paid to supply brand. It's unlikely that you're going to wholesale review and switch all your apixaban patients to, say, rivaroxaban for a month to then change them back, or by the time basically you've done any work on this, the price concession is over and things have gone back to normal. So it's probably useful to have a bit of an idea of what's happening here and a bit of a track of what's on price concession, and this can help you know what the problems are, or you're getting lots of calls. You can have a look here and see, is it in price concession? But beyond that, you're probably not going to do too much with it. You can click through for a bit more information from these price concession pages as well. So I think this Apixaban here is a pretty useful example. So if we click through to Apixaban, we can have a rough idea of what's happened with price. So you can see this is the branded price, and then it's dropped off a cliff as the generics started to come out. And then this is what's happened with the price concession here in green. So there's been a price concession, actually nowhere near what the brand costs. So the brand costs £53 box, probably. I don't quite know how much it costs now. So before, pharmacies were getting reimbursed £2.83 a box. Now they're getting paid £15 a box. So it's definitely higher than it has been, but not as high as it, not as high as the spend on a Apixaban used to be. So just helpful background, not something I think you will use kind of day to day, but worth just being aware and knowing it's there. And on the price concessions, if you are interested, so as soon as price concessions come out, we send out emails. Again, you can't see this on the practice page, but if you look on the PCN page, but if you click through to practice, you can sign up for alerts as well. So for your practice, you can get an email saying this is what you're spending on price concessions roughly this month. And that email will come through probably a couple of times a month, just as we update the data as it gets released. Yeah, right. Okay, so that is price concessions. Then the last few bits I will tidy up. I think we're getting close. Have we got many queues? No questions yet. If you've got any questions, do add them to the Q&A, and we hopefully will have 5 minutes at the end to try and cover any. So one of the other tools you might start to use is Analyse. So if you use the top navigation bar here, there's this button here, Analyse, and here basically you can search for anything. So you can run your own analysis on something you're interested in. We use a very common example just because it's quite an extreme example here. So we use this drug here, pericyaxine, which is an antipsychotic medication. So we know that there's definite variation in how often areas prescribe this. So you can see this is a very extreme example, but you can see here NHS Norfolk and Waveney prescribe 3,833 items a month, whereas the next highest is 61 items a month. So you can see there's something quite extreme going on here. We have things like maps, so you can have a look and see something happening there. Yes, okay, fine. So there's quite a lot happening there, and not much anywhere else in the country. So that's interesting to know, but there might be reasons why. So I don't know, maybe the antipsychotic prescribing rates are much higher in Norfolk. Maybe it's that a lot of it comes from specialist centres elsewhere, but in this sort of area, it all comes from primary care. So you can use things like our denominators here, so versus. So say here, what we might use is antipsychotics. So antipsychotic drugs. So dividing the number of pericyaxine prescriptions by the total number of antipsychotic prescriptions, just to give us an idea and to normalize things. And again, we can still see it's particularly high. So there's definitely something going on here in the Norfolk and Waveney area. I don't think we've ever got to the bottom of what it is. No one really seems to be that clear, but there's obviously something interesting happening here. Probably a more useful example is you might want to see, say, as new drugs come to market. So tirzepatide, a fairly new drug that's come out, and you can see what's happening. Maybe you want to just know what's happening across the country. So you can put in tirzepatide as the drug and the NHS region, show me the data, and you can see how things have taken off over time. So some areas shooting up quicker than others. Again, maybe that's just because they have more patients in those areas, so you can normalize for list size. So you can see London prescribing less tirzepatide per patient on their list than some of the others. I don't know, maybe you'd want to have a look for total diabetic drugs. yeah, you can see London's still low. So you can kind of have a look, find something of interest, have a look, have a dig further, download the data if you want to have a look in more detail, or you can sign up to alerts as well. So if there's something particularly that you want to watch, you can sign up to alerts, and again, you'll get an email every month saying your analysis has been updated. Obviously, if you find something really interesting there or something you think should be a measure, email us, let us know. We're always looking to make new measures, to add new measures, so do let us know when there. And then some last things just to very quickly mention. So we have these trends tools here. So things like trends for BNF sections. So you can see this is the national spend, but you can see what's happening for different BNF sections. So I think anticoagulants is probably one of the most interesting ones at the moment. So you can see spend was going up and up and up. Then as the new generic DOACs have come out, spend is dropping quite suddenly, gone down about 20 million, 25 million a month. So there's been kind of a big drop in spend, and number of items has probably gone up if anything. So helps you keep track there. Then we've done the drug tariff. I don't think any of these others are that relevant. And then obviously we've got our FAQ, so we'll cover things like, what's an item and what's a quantity if you're not sure, or say what sort of data is included there. So there's obviously more complex things about, say vaccinations or things that are administered at, say, a GP practice level, and there's details in our FAQ about what's included there. We've also got our dm+d browser here if you're interested in knowing a bit more about dm+d and what the dm+d information is for a specific drug. And we've got our blog link here. So this, again, I mentioned before, it's now on our homepage, but tells you what's happening with the website, what we're changing, what we're adding, what we're doing. So that's all from this Open Prescribing webinar today. Thank you everyone for joining us. Have a good afternoon. Goodbye.